Earlier.
Dr. Rajesh has come on board. Welcome.
Yeah.
Good evening to everybody. We are speaking two parts. One, I'll speak about the basics about heart transplant and congenital heart disease, followed by we'll discuss some cases with Dr. Devanand. So we all know the 0.4 to 1% of the population has got congenital heart disease, and despite incredible improvement in the surgical repair, still it is not a curable condition, and the majority of them land up in the end-stage heart failure. So currently, probably heart failure is one of the options for this type of patients. Main reason for heart transplant in congenital heart disease is in the newborn, usually hypoplastic left heart syndrome and Epstein's anomaly, severe Epstein's anomaly, and Eisenmenger syndrome in grown-up child, and tetralogy fellow with the complications, univentricular heart with or without phantom circulation, systemic right ventricle. So in the neonate, any cardiac malformation for which the two ventricle repair is not possible or advisable, like hypoplastic left heart syndrome, pulmonary atresia with intact ventricular septum, complete atrioventricular septal defect with severe right or left ventricular dominance, a single ventricle with severe LVOT obstruction, condition at high risk for any corrective surgery, we can consider the neonatal heart transplant. So in a grown-up congenital heart disease, refractory systemic ventricular failure following two ventricular repair, failed Fontan operation, Eisenmenger syndrome, and cardiac tumors. So systemic ventricular dysfunction, they behave like any adult advanced heart failure patient, and most of the selection criteria is similar to adult transplant. So following Fontan operation, those are recurrent ascites, fluid retention, low systemic cardiac output, increased cyanosis, reduced systemic ventricular systolic or diastolic function, and moderately elevated pulmonary vascular resistance, and need for inotropic support. Probably they carry a worse prognosis, so these patients probably be selected for the transplant. So in the Epstein's anomaly, those who had a severely depressed LV systolic function, and other associating like non-compaction cardiomyopathies, and RV diastolic index more than 200 ml per meter square, RVEF less than 40%, age more than 50 years, so they have increased risk of post-op RV failure. So these patients, and also the early intervention probably in the Epstein's may avoid sometimes a heart transplant, but those who have these parameters, probably they may benefit from the transplant. In the cardiac and tumors in the children, so primary cardiac tumors are rarely metastasize. So common tumor like rhabdomyoma, so spontaneous regression also known in case of tuberous sclerosis. So otherwise is indicated in LV dysfunction with hemodynamic compromise, ventricular arrhythmia, or outflow tract obstructions. So what are the contraindications? Absolute contraindications are active infections, severe metabolic diseases, or multiple severe congenital anomalies of other organs, multi-system organ failure, active malignancy, and behavioral problem and cognitive issues also, because they cannot maintain this transplanted heart. So in the heart-lung transplant, so combined heart or lung transplantation or heart-lung transplantation, or lung transplantation with intracardiac repair in patient with a simple congenital heart disease like VSD, ASD, PDA. So in this case, irreversible pulmonary hypertension or inadequate sized pulmonary arteries. Or in adult patient, the main cause for heart-lung transplant is Eisenmenger's with complications, idiopathic pulmonary artery hypertension with complications, and cystic fibrosis. So workup for these patients, usually with the cardiopulmonary exercise test, right heart catheterization, and X-rays and other routine blood investigations, and CT chest, and also ultrasound abdomen and carotid lower limb extremity vascular Doppler should be done. So immunologic assessment like PRA, panel reactive antigens, HLA typing, and so in the prognostication of this patient, so we use a cardiopulmonary exercise test. So the timely identification is possible, is required in case of congenital heart disease. So in patient, traditionally what we use is VO2 max of usually 10 to 14 or 12 to 14 patient without beta blockers in the advanced heart failure, and patient with less than 10 with beta blockers has been a criteria for listing this patient for transplant. Although it has been shown, this study in the adult congenital heart disease, a decreased VO2 is associated with increased mortality, but we don't know exactly whether VO2 max is a definitive listing criteria in case of congenital heart disease, because a threshold are different, or it may be independent of underlying congenital cardiac defect. So in one study of 1,375 patients, so the high risk of death increased with a lower peak VO2 max. So the coming to panel reactive antigen. So these are the screening tests you adopt before transplant. So these are to determine the circulating antibodies to the random panel of donor lymphocytes. So this is basically anti-HLA antibodies to HLA A, B, DR, and DQ. So it shows the degree of sensitization. So usually we consider sensitized when the PRA is above 10%. So in this registry of total 41,849 patients with more than 18 years listed for primary transplantation. So you can see the reoperation group was around 40%, and without reoperation is around 59% in adult congenital heart disease. In the survival, early mortality among patients with congenital heart disease was high. The reoperation was 18.9% or 9.6% in transplant with other causes like dilated cardiomyopathy. In non-reoperation, the early mortality of 16.6% was 6.3% in other transplants. So 10 years overall survival was equivalent 53% in both the groups. So outcome after heart transplantation for congenital heart disease compared to patient with acquired heart disease or congenital heart disease have a higher mortality. So cause of increased perioperative mortality may be due to more complex surgical procedure requiring more reconstructive surgery, or higher bleeding risk, or donor right ventricular failure, either or neonatal requiring ECMO, or prior to the transplantation wall increases the mortality, perioperative mortality. So, and also the increased rejection episode due to more powerful immune system, and also increase preformed HLA antibodies due to prior blood transfusion during the palliative surgeries. Reconstruction of pulmonary artery also cause increased risk of perioperative mortality. The single ventricle following palliation have a worst outcome. The 1, 5, and 10 years survival is 70, 58, and 50%. So prognostication, so tool in the adult congenital heart disease is not well established. So probably because of many reasons. Maybe additionally, this patient may require the aortic arch correction, pulmonary vascular resistance may be high, or may require more complex surgeries. Additionally, maybe a more aortopulmonary collapse which increase the bleeding risk, and more blood transfusion and homograft tissue can also cause more preformed HLA antibodies, can cause more rejections. The more pulmonary venous return can obliterate the surgeon's field. And Fontan patient outcome, it is reported the survival was 77% at 1 year and 67% as 5 years, significantly lower compared with 91% at 1 year and 81% at 5 years in the non-congenital heart disease patient. It may be due to early graft failure in 17%, infection in 30%, and hemorrhage and operative complication in 9%, which increase the mortality risk. And also the patient undergoing heart transplant due to failing Fontan were more likely to require pulmonary artery reconstruction, and 90 days mortality rate was 35% among these patients. And long-term survival after heart transplantation performed in 13 adolescent adult was 77% in 20 years. So, which shows that there is increased mortality among adult congenital heart disease compared to patient who undergone non-congenital heart disease patient. So thank you. So over to Dr. Devana.
So, Dr. Devanand, can you start sharing your screen?
I'll just share now. Yeah, can you see me, Jay? Screen is seen?
Yes.
Yeah, you can go ahead.
Yeah. Respected chairpersons, I would like to thank the scientific committee of PCSI for this opportunity. As Dr. Malesh already said, now we are seeing increasing number of children who are growing into the adulthood following corrections of the congenital heart defects. It is said that children who, almost 90% of them reach the adulthood, of which almost 26 to 42% die finally because of heart failure itself. But when you look at the amount of transplants that is being done for the adult congenital heart disease, it's only around 3 to 3.5% according to the ISHLT data in the last 10 years or so. Before that, it was around 2.2%. Now, what we should note is this is a heterogeneous group of patients. We have systemic ventricles, which are formed by the right ventricle, corrected transposition, either corrected or uncorrected, physiologically corrected or uncorrected, all kinds of univentricular hearts, and non-compaction, which is much more common, prevalent amongst the congenital heart disease patients. All these things finally end up in heart failure. Now, the pathogenesis was already told by Dr. Malesh. There is going to be intrinsic myocardial dysfunction, maybe because of non-compaction or maybe because of long-standing cyanosis. There could be chronic volume overload, again because of multiple corrected, uncorrected shunts, pressure overload from residual obstructive lesions. There could be pulmonary as well as systemic hypertension, maybe related to the age, maybe related to the partly corrected coarctation, etc. And some of these patients do land up in heart failure because of poorly controlled arrhythmias. Now, indications, again, Dr. Malesh told that it's a standard indication. Whatever we are using for the adults are also used for congenital heart diseases. Single or biventricular failure requiring multiple hospitalization, refractory to medical treatment. Those on stage C or NOHA class 3, where VO2 max falls less than 12, probably fall into the group of heart transplantation. Progressive cyanosis, when the functionality also declines and nothing much can be done to improve the cyanosis, would also probably qualify for an early transplant than late. These are some unconventional indications practically. Fontan failure, again, which are failing significantly, almost going into protein-losing enteropathy, should also be considered early for transplantation, and refractory arrhythmias. Now, absolute indications, we heard. Contraindications, very few. Pulmonary vascular resistance beyond 4 to 5 Wood units, and other general things like malignancy, infections, substance addiction, etc. Some of the relative contraindications are increased BMI, chronic liver disease, chronic renal disease are very high PRA levels. These are all relative because now multi-organ transplantations are also happening. Liver with heart, liver with kidney, or heart with kidney is possible. And PRA, if you desensitize them adequately well in time, probably they can go through transplantation. These are some of the very important considerations when we're considering transplantation in adult congenital heart disease patients. Reviewing the patient's surgical history is very, very important because we all know that lots of these patients, at least 50-60% of them would have had multiple interventions of one or the other kind, surgical or non-surgical. So knowing the absolute surgical history, what was done in the past, including simple like for surgeons, like how much pericardium was used, whether pericardium was even closed or not closed, everything matters to the outcome. And the current anatomy, again, is very, very important. Where are we just before the transplant? Especially when it comes to systemic venous connection, pulmonary venous obstructions and other things, pulmonary arterial anatomy, and aortic arch anatomy. Patency of femoral vessels are very, very important again because you have to plan your CPB access because of multiple catheterizations or sometimes long stay with the femoral arterial groin vessels for inotropes and pressure management. We do see problems with this access. AP collateral burden to be looked into. If something needs to be embolized, they should be embolized wherever possible. And as already said, panel of reactive antibodies levels are very important. Anything more than 10%, probably it may be wise to desensitize them even before listing them onto the transplantation. So we need to plan our CPB access in case of a problem while doing repeat sternotomies. We need to estimate our own time based on our own surgical ability as well as our system ability, how much time probably I might need to dissect the heart out of the chest cavity. And what additional material that might be required, like pericardium or a piece of homograft, etc. Do we have that to place a normal heart into a chest with complex either venous or pulmonary anatomy? Now, perioperative care is again standard. Only a few things which are important, as I said repeatedly, is planning the CPB access most important. Meticulous hemostasis is absolutely important because that is one of the risk factors for early death. Following other safety measures like transesophageal echo, cerebral oximetry, the cytosol therapy. This is something which has come up now, and we have some experience in using this in transplant as well as non-transplant patients where a pump time is going to be prolonged. This is supposed to scavenge at least the inflammatory substances in the blood at the end of the pump run. Liberal use of cryoprecipitate, factor 7, etc. should be done to achieve good hemostasis because some of these patients do have long-standing liver congestion and probably some issues with the clotting system. Use of milrinone, one should be very liberal. So also the inhaled nitric oxide, because we know that significant amount of these patients can have increased pulmonary vascular resistance. There should be low threshold for the ECMO for the same reason, because once we tide over the crisis, these patients do very well. Immune induction, I think, is a must. I do not think anybody else, anybody is doing transplants today without immune induction. Early endomyocardial biopsy to pick up an early rejection is very important. Preoperative CT goes a long way apart from the angiography. This is some of our own patients where you can see one who had preoperative outline, hugely aneurysmally dilated SVC. And here we can see how in the aorta and PA are lying in a DIVO or VTJ kind of situation. Mentally, we get a picture that what we are into when we are planning to transplant these patients. Similar, another patient, again, hugely dilated SVC, ill-posed aorta. Same thing. Outcome in adult congenital heart transplant patient, in fact, is much better than non-congenital, transplant for non-congenital heart diseases, if you look at that. It's only that the early operative or perioperative 30-day mortality is only significantly high compared to the other causes of transplantation. But as the time goes, you see that the survivability is far, far superior. It may be just because they're younger patients with very least amount of other risk factors. Median survival, if you look at it, 15 years is the median survival of these patients compared to all other patients. It's not so bad. Now, the mortality is slightly different. Early mortality is fairly high. 30-day mortality is almost 17% versus 7% in non-congenital group. But as the time goes on, 10-year mortality, in fact, is slightly better in transplants for congenital heart diseases compared to other transplants. Now, mortality in the immediate perioperative period is high, probably because of various reasons. One is longer ischemic time, because you need that kind of time to re-enter and get the heart out of the chest. Chances of bleeding again are high because so many of them could be cyanotics. There are multiple smaller collaterals. Many a times pericardium on either side is used, and heart may be badly adherent to the lung. And increased donor RV dysfunction because of higher PVR. And vasoplegia is one more, again, common thing which we see because of long pump run as well as because of long-standing cyanosis. This is something which is very less commonly used. Mechanical circulatory support for heart failure in adult congenital heart disease is very, very less often used according to the Intermax data, less than 1%. But those who were supported, there were some observations that were made. Death before transplant was more or less the same. But BiVAD, those patients who required BiVAD or total hearts were the ones who fared very, very badly. Otherwise, those who were on mechanical circulatory support itself, there was not much of difference as far as the survival. Now with that, I'll just present 3 short cases. The case 1 was a 30-year-old male, A negative blood group with single ventricle of RV morphology, PSTGA, with severe single ventricular dysfunction, EF of around 30%. He was in regular phlebotomy. He had 1 episode of VT, at least it could be cardioverted. Cath was favorable for transplant, PVR was 1.8. So he had a transplantation with a donor was a 32-year-old male. Not much. His total ischemia time was just 130 minutes, including the transport time. Very smooth recovery. Only 8 months down, he developed invasive aspergillosis in terms of lymph nodes, but he responded very well to antifungal medications. Now, after the 6th year, he's doing very well without any issue with his annual endomyocardial biopsy as well as coronary angiographies. Case 2 is a 42-year-old male, NYHA class 3. This person, again, was a single ventricle, but partly palliated. He had undergone BDG in 97 and MAPCA embolizations of multiple MAPCAs in 98. But of late, before transplant, within 2 years, he had at least 3 admissions for congestive heart failure. Cath data again was quite favorable. He got a 25-year-old donor, but his cold ischemia was slightly prolonged because he was second time chest re-entry. CP was prolonged. This fellow had a rough course, even though the operation went very well, could be extubated within a day. He required multiple tubes for recurrent effusion. Respiratory drive was not the best. He was also a kind of slightly poorly motivated patient, I would say. Anyway, on 23rd day, his biopsy showed antibody-mediated rejection. So standard protocols were followed, like pulse prednisolone, plasmapheresis, IVIG. He was doing still okay, never went back on ventilator or anything, but on 28th day, he deteriorated all of a sudden. There was massive hematochezia, and we put him back on ventilator and did the colonoscopy. Emergency colonoscopy showed entire cecum and the colon was completely necrotized. So he died within few hours without any other intervention. Case 3 was 22-year-old male, NYHA class 3 for DORV TGA with inlet VSD and PS. He had undergone septectomy with PA bed in 2000, because when they opened up, they thought probably his VSD was completely inlet and it's not possible to route it to aorta. So he came back to us in 2011 with significant heart failure. Surprisingly, his left ventricular dysfunction was significant, 30 to 35%. When we looked at the data, he developed this isolated left ventricular dysfunction 6 months following the initial operation. I do not know the reason. What was the cause for this? Maybe intercurrent viral myocarditis or something. So he was refused surgery. So when we did the cath, his PA pressures are slightly on the higher side. So ejection fraction of 35%, not certainly a good candidate for a BDG. So we decided to do two ventricular repair in 2011. He went through kind of hemimustard at a Glenn, MPA-plasty and VSD closure. Basically, we created a corrected transposition in him, with which he lasted for another 6 to 7 years. Even though he symptomatically was saying he's in class 2, his ejection fraction had come down, biventricular ejection fraction dropped down to almost 20-25%. His ECG was quite bad with very wide QRS. So his when we did his CPET, cardiopulmonary exercise test, his VO2 max was quite low. So we listed him for transplant. Fortunately, his transplant very well, even though his cold ischemia was almost more than 3 hours and CPB was 277 minutes. He has had a smooth recovery, but only just 2 years from the transplant. And just 2 months ago, he came with antibody-mediated rejection, treated well, and at the moment he's doing good. So, yeah. So I would conclude saying that it is doable, but only thing it requires meticulous pre-planning to have a good success. Thank you very much.